The evidence for prevention is strong, clear, but this evidence alone does not lower risk. Patients must be identified, treated, followed, and supported. The future is not only better prediction, it's better delivery over time. And the clinical value is the risk estimation, treatment effect, persistence, and access. These are the important things for a real effective prevention. Latest data show that mortality has improved in Europe, but the improvement is not equal. Middle-income countries still have higher cardiovascular mortality. This means prevention must be adapted to the setting. Equity is part of this implementation. European data also show that risk factors such as tobacco, physical inactivity, hypertension, obesity, and diabetes vary by sex and income. This means that risk factors are not evenly distributed. They vary by country, sex, and income, and this affects both population policy and the clinical care. Local epidemiology should guide these local priorities. We know very well that atherosclerosis begins early and the risk accumulates over the decades, and the same LDL cholesterol or blood pressure level has more effect when exposure starts early, and this supports prevention before the symptoms appear. A life course prevention, and the prevention should begin as early as possible. A static score gives only estimate at one time point. This is very important, but cardiovascular risk follows a trajectory. As clinicians, we should ask how fast the patient is moving toward the disease, and the earlier control changes the slope. Therefore, the follow-up should reassess trajectory, and early treatment can change this curve. This is really important in prevention. For the management, for the prevention, first of all, we have to begin with risk stratification. This means that we have to start with clinical category. This means that exploring the patients having cardiovascular disease, diabetes, chronic kidney disease, presence of FH, a severe single risk factor presence. Then we have to use the calibrated absolute risk. This means averaging calibrated 10-year fatal or non-fatal cardiovascular risk. In Europe, we use score 2 or score 2 OP for older persons, and then we have to add the modifiers, risk modifiers, and decision enhancers only when they change management. For risk modifiers, we have the family history, lipoprotein little a levels, sex-specific factors, inflammatory disease, and sleep apnea, for example. And as a decision enhancers, we have the imaging, calcium score, plaque imaging, and ankle brachial index, and organ damage in hypertension, and also we have the frailty as a decision enhancer. And the next and the final step is a shared treatment plan. This covers the targets, treatment intensity, timeline, and follow-up. 10-year risk rises very significantly with age. We have to keep in mind this is important, but we should not forget about the younger patients because they may look low risk when we use the 10-year estimates, but their lifetime benefit may be large. This is why lifetime risk should be discussed with younger patients. This is very important. Risk modifiers are useful when the risk estimate is uncertain. They should change the intensity, timing, and acceptability of the treatment. They also have to communicate the risk. Here we have the family history of premature ASCVD, high LP(a) levels, sex-specific factors such as menopause, premature PCOS, and pregnancy-associated outcomes, chronic kidney disease, inflammation, psychosocial burden here, stress and deprivation, and plaque imaging, which enables us about the direct disease evidence. In the slides, you see the imaging and biomarkers as decision enhancers, but the rule here is actionability. I mean that they should not become screening reflexes. The test result should change our treatment or improve adherence. So we have to order the test. Only the test result can alter management and, as I said, improve the adherence. Lifetime risk is driven by cumulative exposure. As you can see here, the pink bars represent the untreated cumulative exposure, and the green ones are earlier control exposure. So earlier control significantly lowers the area under the curve, and this is especially important for LDL cholesterol, blood pressure, smoking, diabetes, and obesity. And this concept helps explaining urgency to younger patients. Another important point that we have to keep in mind that the risk factors cluster. Their effects may be multiplicative, not merely additive. Social and environmental determinants amplify the biological risk, and this is why single-factor care is insufficient. And the ideal cardiovascular health is multi-domain. It requires the management from different perspectives, and lifestyle, metabolic factors, and environment are connected, and improving one area really helps to others, but durable prevention needs combined action. So this means that healthy diet, physical activity, no nicotine exposure, adequate sleep should be combined with the classical risk factor management. And from risk stratification to implementation, we have to see implementation as a cycle. Risk is assessed, benefit is communicated with the patient, we have to set the targets and intensify treatment, and treatment should be sustained by monitoring, and then the cycle repeats. This is really important for the success or getting the targets. And at patient level, health literacy, preventions, beliefs, social support, and cost all will affect this implementation. On clinician levels, time, knowledge, risk communication, therapeutic inertia are important, and at the system level, access to therapies, pathways, coverage, register result, quality indicators should always be used. At system level, under implementation, the evidence to practice gap we measure with these registries. And I just gave some registers names from Europe and world, and also my country Turkey as the FSS study. All these show that most of the patients do not reach guideline targets. The problem is well described in the European real-world data. LDL goal remains difficult to achieve. That's the biggest problem. Lifestyle and adherence gaps also persist, and implementation is now a major clinical priority in the prevention of cardiovascular disease. The barriers for implementation exist at several levels: patient, clinician level, system level, intervention level, and also societal level. Patient factors are really important. Low health literacy, poor adherence, cost are important. Clinician and system factors also matter here. The inertia, limited access, fragmented care, and cost are major barriers, coverage especially here. Interventions must be simple. This is really important. They should be simple enough to maintain, but complex regimens, side effects can be barriers here, and societal conditions can either support or block the prevention. This is covering the public health policies, community programs, inequality, unhealthy environments are the components of these societal factors. Adherence and persistence determine long-term benefit. Initiation is not enough. Treatment must be taken and continued forever. And therapeutic inertia also reduces this benefit. The system should make escalation easy. So it will be simplified, and we have to measure scheduled lipid and blood pressure checks. We have to explain the goals to patient and side effects, really, really important. And we have to act for the default escalation pathways. Digital help is really helpful in implementation, the prevention, but it should reduce the work, not add noise here. Its value is a closed loop. Data must lead to clinical action. This is important, and feedback must return to the patient and clinician. So measure what matters, automate the next step, and make failure visible to gain success. These are important steps here. An important pillar is here precision medicine, precision prevention. It includes genomics, biomarkers, and imaging. But precision should not mean adding complexity without benefit. Every tool should be judged by actionability, equity, and outcomes. So genomics, biomarkers, imaging, decision support in implementing science is here, but the future tools should be judged by clinical validity, cost effectiveness, equity, usability, and outcomes. When we are talking about trajectory-based prediction instead of a single 10-year estimate at one time, we have to be sure that trajectory-based prediction asks a broader question. It follows exposure, disease, and the care over time. It should guide intensity and timing, and it should also identify patients who need more support. So prediction should guide intensity, timing, and delivery. So this is a dynamic risk profile. The exposure trajectory, disease trajectory, and care trajectory are determined, and this also determines the treatment intensity, follow-up intervals, and system support. Another important thing about precision care, it must not widen inequality. Clinical care is essential for high-risk patients, but policy and system support are needed for population impact. This is prime of importance, and the future of prevention must be scalable. We have two routes to lower the risk. At the left-hand side, you see the population-based strategy. It lowers the risk of the whole population. For example, healthy lifestyle, such as a smoking ban. These are public health policies. And at the right-hand side, you see the high-risk strategy. in the population, you find the high-risk groups and you directly treat this high-risk tail. But these two approaches should not compete, and the optimal prevention needs the both. So combining strategies at the population level and at the same time finding the high-risk patients, populations, it is when we apply both of them, we get the real success. The future prevention clinic should combine precision and implementation. Risk assessment is only the first step. Treatment pathways, follow-up, acuity checks, and registries are equally important here, and the aim is sustained risk reduction. I want to close with 5 messages. Prevention is lifelong. Risk assessment must include lifetime and residual risk. Prediction should follow the patient trajectory. Implementation determines the impact, and future prevention must be precise and equitable. Thanks for your attention.